talk by Dr. Parveen, who will speak on multifocal ERG and pattern ERG. If you have any questions, just keep them and we'll take all the questions together. Great.
So very good afternoon to everyone, and many thanks to the AIOC Scientific Committee as well as Dr. Purnachandra for his efforts to put this session together. So Dr. Ma'am and Dr. Purnachandra both have spoken very well on full field electrophysiology and what are the origins. So one limitation of full field ERG is that, as the name suggests, it gives the mass response, and we've all heard and read that almost 50% of the retina has to be malfunctioning for it to show any response or any effect on the full field electroretinogram. So what happens in macular dystrophies? A macula, we know, forms less than 10%, and if there is a macular dystrophy, the patient will have poor vision, yet your full field ERG would be normal. So to address these conditions, we have special tests, which is the multifocal ERG and the pattern ERG. So the need, as I said, the need is to display the topography or the malfunction in the macular area, which may not be picked up on a full field ERG. Also, full field ERG gives you the option of seeing both the rod as well as cone photoreceptor function, but multifocal ERG is largely cone driven because it is done under light adapted conditions. And as I said, it is the entire retina which is measured in full field ERG, while in multifocal ERG it is the central area or the macula which is determined, the health of the macula which is determined. Principle, it is done how it is recorded: pupillary dilatation, light adaptation, and room illumination, and we have various stimuli which can be used. I'll show you the specific stimuli, and the electrode used is the Berlin-Allen electrode. And fixation is of utmost importance because it is giving you topography. If the patient is fixating elsewhere, the whole topography changes. So the fixation should be monitored throughout, which can be either in form of crosses or rim spots in the center, and the refractive error correction has to be in place. This is the special kind of stimulus which is used for multifocal ERG. It is called the random or the pseudo-random actually. Why pseudo? Because it looks random, but there's nothing random about it. It blinks and changes from dark to light according to a set algorithm, so much so that it ensures that 50% of the hexagons are on and 50% are off. And even the size of the hexagon is scaled, so you can see that the size of the hexagons is smaller in the central area because here the density of cones is more. So each hexagon is stimulating equal number of cones across the central 40 degrees. So you could have 37 stimuli, you could have 61, you could have 103 or 241. So how do you choose? So in a non-cooperative patient, 61 is much easier because time taken is lesser, patient cooperation required is lesser, but only thing is that the resolution that it will give you, it's almost like the pixels, so the resolution that it will give you is less, and the smaller area of disease may be missed. It can also give you in form of ring that 0 to 1 degree or 6 degree, how much is so which area, is it the fovea involved or the perifovea or the parafovea which is involved. This is one of the we all look quickly for this, but actually though it looks very pleasing when you look at, this is not the best way of interpreting multifocal ERG. The best way is to look for the trace arrays. So, but it quickly gives you the distribution. It tells you whether the superior area retina is involved or inferior is involved. Dr. Subhadra spoke about the origin, and it is first thing to remember, it is cone driven. Why? Because it is always done under light adapted conditions. The P1 and N1 waves are almost similar to A and B wave of a full field ERG. Why I said almost? Because it not only depends upon whether it is light flash or dark flash, also depends upon whether the previous flash was light or dark. So it is a kernel or a mathematical algorithmic extraction which is given to us. It is interpreted in the same way, where N1 is usually represents the A wave, and it comes from the photoreceptors, and a decrease in amplitude suggests cell death, whereas delay in implicit time or latency is usually suggestive of malfunction. So this is some typical form of MFERGs where you could have central defect, the periphery is normal, something like a Stargardt's disease, generalized peripheral abnormality, only central preservation, typical of RP, generalized reduction, which is seen in cone rod, that both cones and rod affected, and localized, say here the inferior field is affected, what you may see in a branch retinal vein occlusions. Very mindful for artifacts, because artifacts can be very often seen in these cases of MFERG, and typical is this, the second one here, where you may see that waveforms are there, but this three-peak waveform is nothing but electrical noise. This is how it looks. So you must get used to identifying the waveforms, because you may get a topographical map with even this kind of a noise. Here you can see that waveforms in the superior area is much better than here, but this is nothing but eccentric fixation. Just taking you to a few examples here to look at. Both the retina look almost similar, but if you see, in fact the ERG also looks similar, because in the early stages of cone rod dystrophy in a young patient, the cones may not be so subnormal, but you see that MFERG is already non-recordable. And Stargardt's disease, you can see that the central area is the one which is depressed, but the periphery is better. Retinitis pigmentosa, as I showed, that the central area responses may be better. In fact, this is again very, very useful, because in our latest cases of gene therapy, the only way you can find out whether the gene therapy is working or not is by doing an MFERG. Why? Because full field ERG still remains extinguished, and for you to see any measurable change in gene therapy, I think we are very far away from that endpoint. So in occult kind of macular dystrophies also, you may have only MFERG which can help you determine the dysfunction, because full field ERG may be normal. MFERG is vital in drug toxicity, especially in cases of hydroxychloroquine toxicity, where this test is one of the preferred tests for looking at the toxicity in addition to OCT. Chloroquine toxicity is another one. Without going into too much of detail, you can see that the central areas are affected early on. Hydroxychloroquine, as I said, that this forms one of the recommended screening tests for. Why I think OCT is coming ahead of MFERG is, sadly, the availability of OCT is much more than MFERG, so they say that OCT is a must. MFERG, wherever possible, actually it will give you a better and earlier affection. Vigabatrin is used as an anti-epileptic, and it is known to cause visual field defects. Sometimes children find it difficult to respond to this kind of a test of perimetry. In them, multifocal ERG can also be done, and it is more sensitive. And desferoxamine toxicity, this is also again another more than drug toxicity. There are some acquired or non-congenital disorders of retina also which can be picked up on MFERG. In fact, MFERG was one of the first tests which first told us that central serous chorioretinopathy is actually not only a macular disease but a widespread affection of the retina, because whenever MFERG was done in patients of CSE, you saw widespread affection of the responses. Diabetic retinopathy, MFERG is again very much into the forefront now. Why? Because even in patients without an obvious diabetic retinopathy visible clinically, the MFERG is affected, and this corresponds to the areas of affection. Healthy areas may actually have normal MFERG, while unhealthy may have affection early on. In neurodegenerative diseases like Alzheimer's as well, MFERG has been shown to be abnormal right in the beginning. Most important caveat for me is, do not try and interpret MFERG without first looking at the full field response of the retina. If you document that that is normal and then go to MFERG, it will make a lot more sense. Just another couple of minutes I have, I will introduce you to pattern ARG. I can't tell it in detail. And it is recorded by using detail electrodes, two components, the P50 and N95. The importance of pattern ERG is that it delineates the macular dysfunction from optic nerve dysfunction, where P50 shows you the macular dysfunction, N95 shows you the optic nerve dysfunction, and in optic nerve diseases, selective loss of N95 will happen. In macular diseases, P50 will be reduced in addition to a decrease in N95. So why pattern ERG and not ERG for optic nerve dysfunction? Because whenever you give a stimulus in form of a pattern to the retina, it is the function of the ganglion cells to pick it up, which is why the pattern ERG is coming into the foray. So just as I said, that P50 is the if you have a fulfilled ERG which is normal, but P50 which is down, it is a clear indication of a maculopathy, right? So it complements fulfilled ERG. And most important, this is something which you may think, why not pattern VEP as well? So here, look at it. This is just macular edema, but what is happening to pattern VEP? It is already down, which is because large part of optic nerve is formed by the decussating fibers from the macula. So if macula is abnormal, pattern VEP automatically will become abnormal, even if the optic nerve is healthy. So only if pattern VEP is down along with a decrease in N95 can you definitely say that it is optic nerve dysfunction which is causing it. And the typical example which I'll share with you, only one example, is that of pattern ERG in acute optic nerve demyelination or optic neuritis. We know that within the first 3 weeks it will be unrecordable. Why? Because first 3 weeks you have a sudden drop in vision. So when the visual acuity is poor, eye does not recognize the pattern, and all P50, N95, all components go away. But as the visual acuity improves, you have improvement in P50, but N95 remains subnormal. So this is typical that this is an optic nerve disease that you are looking at. So that's all for today. Thank you.
Thanks.